Hey guys, welcome to the first lesson in our trauma series. Today, we're going to go over the trauma survey. So, this quote really kind of says it all. The trauma survey, when we do it properly, can spot any and all life threatening injuries. As soon as we find out what's happening to our patient, we can take care of them. You'll see that in emergency medicine, we use a whole lot of mnemonics. As providers who can treat anything that comes through the door, it helps to have little hints to remember these things. So, the easiest way to remember the steps of the trauma survey is by using the A to I mnemonic. The initial survey, it's broken down into the primary and the secondary survey. And the primary survey consists of A for airway, B for breathing, C for circulation, D for disability, and E for expose or environmental control. We move on to the secondary survey, which consists of a full set of vitals and talking about family presence, getting resuscitation adjuncts, and giving comfort measures, a head-to-toe assessment, and a history, and then inspecting the posterior surfaces. So we start with airway. Does our patient have one? Well, can he talk? If your patient can talk, he probably has an airway, and it's a really good way to assess his level of alertness. We use the mnemonic AVPU, which stands for alert, verbal, pain, and unresponsive. So what does that mean? Well, if your guy comes in and says, "Hey there, fine hospital you have here. I'd like you to fix me up and discharge me as soon as you can." Well, then guess what? He's alert. And he also probably has an airway. If the patient's talking, whether they make sense or not, they usually have an airway. So then we move on to verbal. And verbal means that the guy comes in with his eyes closed, you say his name, and he opens his eyes. He is responsive to verbal stimuli. Pain is just that. Same guy comes in, you shout, you get no response. So you decide to use painful stimuli, and this can be like a sternal rub or a trapezius pinch right on the shoulder, or maybe when you put in an angiocath. If you get no response, if you get a response to any of those things, then he's responsive to painful stimuli. And unresponsive is just that. You got nothing. So I want you guys to see this picture here. In any trauma, as we're assessing the airway, we always want to maintain C-spine, like these guys are here, right? It's a terrible arrow. Anyway, if you look at the guy's hands in this pic right here, that's a pretty good way to maintain manual stabilization, is by placing your hands on both sides of the head. I find that for myself, I like to bring my hands down to the collarbones and kind of lock my thumbs in there, and thereby my forearms are actually providing a bit more stabilization to the sides of the head. And the reason that we do this when we're maintaining the airway is that we find that a lot of times when you're trying to assess the airway, you see the docs kind of moving the head a little more than they maybe should. So it becomes our job to really keep that C-spine in alignment to prevent any further injuries. So then we move on to breathing. And breathing in trauma is just like any other breathing assessment with a few minor tweaks. So after we've looked and we've listened, we're going to put our hands on the patient and feel for something called bony crepitus. And what that is, it kind of feels like rubbing two cinder blocks together. It's that grinding sensation. Also, very bad, needs to be treated. Okay, so we've assessed airway and breathing, and depending on how a guy is doing at this point, we want to think about giving him oxygen. If his airway is patent and he's breathing on his own, just give him a non-rebreather. That's going to do the trick. If his level of consciousness is low or he can't protect his own airway, you should start with a bag valve mask, but then we want to think about intubating, usually with something called RSI, or rapid sequence intubation. So we have our airway, our guy is breathing, and now it's time to assess circulation. So we all know that blood outside the body is a bad thing, right? If we remember that in trauma, you're all going to do pretty well. It's our job to control life-threatening hemorrhages. So traumas are the time when you'll see a lot of hospitals now using something called a massive transfusion protocol. It may have a different name, but the concept is the same. It's bringing up large amounts of blood from the blood bank in a cooler at one time. Blood, platelets, cryo. You want to have that on hand to give to the patient as fast as you can, rather than running back and forth to the blood bank 9 times. Bring it all at once. So Our guy is leaking, but what's more important, does he have a pulse? We're going to assess it by checking a central pulse. That's a carotid or femoral, the neck of the leg, not a peripheral, okay? So if our guy has no pulse, well, what do? Well, it's the same as any other time when a guy has no pulse. Say it with me, guys. Start CPR. Simple. We're going to do CPR until we get a pulse, or what we call the return of spontaneous circulation, or ROSC. Or, of course, the doc calls it and we're done. We never stop compressions unless we're doing a pulse check or we're defibrillating or the case is over. So our guy has a pulse. We're going to continue with our assessment, right? We're looking for any bleeding throughout the body. We're assessing the skin, the color, the temperature, and we do that by actually touching our guy or palpating. Good. So we have A, B, and C. Let's move on to D, disability. Now, I'm not talking about physical disabilities like if your guy's deaf or only has one leg. We're talking about neurological disabilities. This is where we want to assess and document mental status. In the trauma bay, we use something called the Glasgow Coma Scale, or GCS. There's a great lesson on how to assess GCS in our Med-Surg head-to-toe neuro assessment lesson. Go there, check it out if you need a refresher on GCS. So if there's one thing I can tell you about GCS, and I say this because I've seen it documented many times, a patient cannot, I repeat, a patient cannot have a GCS of 0. The lowest possible score is 3. That's it. That's the lowest score you can have. That means there's no verbal response, no eye opening, and no motor function. Nada. Nothing. Still a score of 3. Technically, the screen you're watching this on has a GCS of 3. So please, never, ever document a GCS of 3. All right. So a very common trauma presentation is that of a head injury, kind of like the one in this picture here. For the record, this guy has a subdural hematoma with a midline shift. What does that mean? Well, the subdural hematoma is all the blood that's collecting here, all that white matter there. And the midline shift, if you look at this white line, you kind of see it's leaning towards the left, right? This should be in the middle. That is a midline shift. This is a bad situation. And for our purposes, what we want to bear in mind with this guy is his comfort level and his position. We want to leave him either supine or raise the head of the bed about 30 to 40 degrees, which is going to facilitate blood flow. The thing that we got to watch for here is signs of increasing intracranial pressure. And you can check one of our neuro lessons on those signs and symptoms to keep in mind. So now it's time to get the rest of the patient's clothes off. In most traumas, we'll grab our trauma shears and we start cutting right away, right? We get the shirt open, we get the pant legs open, and we get some exposure to the patient. At this point, we want to get it all off. Underwear, t-shirts, bras, get them naked. And very important, get everything out from underneath your patient. When we pull things out from under the patient, we can actually see if the clothes are bloodstained. And if they are, it's really indicative that there's another problem underneath that we haven't seen yet. So now we have a naked and cold patient in the ER. Well, let's get them warm. We can use blankets, raise the temperature, give warm IV fluids, warm air circulators like a bear hugger if you have it, and radiant heat lamps. Some facilities will have those. For me, I found that one of the most vital pieces of equipment in the ER is a blanket warmer. If you have one, great. Make sure it's stocked. So our primary survey is done. Now we want to move on to the secondary survey. And the first step is full set of vitals and family presence. When we talk about vitals, we know heart rate, blood pressure, respirations. But the important thing is our first blood pressure, we want to make manual. Both the ACS, the American College of Surgeons, and the Emergency Nurses Association recommend manual first. And the reason being, very traditionally, we throw them on the automatics. The problem is we don't know if the automatic works. So to always make sure that the first blood pressure we get is right, we want to do a manual. Compare it to the automatic next. If they're equal, great. Stick with the automatic. If not, continue with manuals. While we're doing this, we want to think about bringing the family in the room. Now, some people balk at this and say, well, don't let them see that. But studies are actually showing that family presence actually facilitates the healing process. It facilitates them accepting what's going on with their family member. They can actually see the work that's being done on their loved ones. Well, we have to figure out who's going to do this. Well, it can be anybody in the room, really, a nurse, a PA, a resident, but the best people suited for this are usually social workers or members of the chaplaincy. They're trained to deal with families in traumatic situations a little more than we are. And since they don't have actual hands on the patient, they're perfectly situated to help with the families. So now we need to get resuscitation adjuncts. What does that mean? Well, these are the things that are really going to help us understand how sick our guy is. It's one thing to see external injuries, right? It's another to know what's going on inside. And the way we do that is with Elemental P labs. And we want, all the basics, and we maybe do an alcohol and a tox screen. We'll also get probably an arterial blood gas and a venous blood gas to help give us a lactate level and a base deficit. Monitor. Well, get them on the monitor and keep watching for any arrhythmias. Okay. And for NGT, nasogastric tube or oral gastric tube, and we're also going to put a Foley in at this point. The NGT and OGT tube are going to help prevent aspiration. The Foley is going to keep an eye on urine output. Oxygenation. They're getting some sort, right? So we want them either on the pulse ox, or even better would be if you have capnography. Capnography is usually a better indication of oxygenation than just the pulse ox. Capnography. Yeah, if you have one of those, throw it on your patient's finger. That's a much better way of assessing oxygen level. And then pain management. Like I said, the guy's probably broken. It's probably going to hurt. Don't be afraid to medicate him. When we talk about pain meds and comfort measures, those blankets, those pain meds, the distraction, you guys know your pain relief techniques. Use them all for your trauma patients, all right? So then we get into the history and the head-to-toe assessment. There's a reason this is letter H, and it's basically because we can actually take care of our patients without this information. Look what we've done already, right? However, it is really good to have this stuff. The first part of information we're going to get is from EMS in the form of what we call the MIST. And that stands for the mechanism of injury, the injuries they've sustained or identified in the field, the signs and symptoms they were showing, and the treatments that EMS gave them. It's really important to know, did EMS give epi? Did EMS, intubate a guy? Did EMS wrap a wound that we haven't seen? The important thing when EMS is giving their report is everyone has to be quiet. This is a silent room when EMS gives report because we don't want to miss anything they've said. So we've gone through the primary survey and we kind of want to get some more info about our patient, right? So if they're awake and alert, great. We can ask them directly. Hopefully we've assessed their orientation level prior to this, because if you ask him about events leading up to the injury and he says he was breakdancing on the moon with the Pope, I think it's safe to assume he's a little bit confused. In that situation, or if they can't respond, we're going to need to try to find a family or friend to give us some info. So to get a quick verbal history, we use SAMPLE. Which stands for symptoms they were having, signs and symptoms, any allergies to medications or otherwise, any meds they're taking, past pertinent medical history, their last oral intake, and the events leading up to what happened. And the reason that we want to know about the events leading up to it is because if they tripped and fell and broke their wrist, cool, no big deal. Very simple. But if they got dizzy and then fell so hard that they dislocated their shoulder, well, why were they dizzy? That's going to require a little bit more investigation, right? So we've got our information, we've got our history. Now we do our head-to-toe assessment. Now, I'm not going to go into a full head-to-toe assessment here, as there are some amazing lessons all over nrsng.com. Go check them out. I will, however, say it's very important in trauma to avoid tunnel vision. What I mean here is that it's really easy to focus on an upper extremity amputation, but don't put all your focus here and ignore the open posterior head wound that's saturating the bed with blood, right? Don't focus on one thing. Always look at your whole patient. All right, so we're up to the last step of the trauma survey. We've checked them from head to toe in the front. Now we need to see their back. So they're naked. Now we roll them. Okay, maintaining C-spine, we inspect their back from head to toe, right? One of the parts of this inspection, it's usually performed by one of the docs on hand, is a quick rectal exam, lovingly known in some circles as the trauma handshake. And what is that looking for? Well, we're looking for both blood and rectal tone. And if we see blood, well, that's basically a sign of bleeding, right? Which we don't like rectal bleeding. Decreased rectal tone is a sign of usually a spinal injury or some sort of neurological injury, and we got to look at that further. So our initial survey is done. At this point, we reassess all of our interventions and continue to trend the vital signs and address any changes. So I threw this picture in, guys, because I just happen to really like this picture. It kind of shows a trauma team at work. And I want you to look at the important things here. So we have our guy at the head of the bed here, probably one of the docs, right? He's maintaining C-spine stabilization. If you see, remember what I was talking about? See how his hands are all the way down the neck, kind of locked into the collarbone? I like that. So we've got the doc there. We got a doc on each side. His clothes have been removed and placed in a nice pile on the floor. Wonderful. He's got some fluids hanging, right? I think there are 3 nurses in the room here. I think this is our bedside nurse here. I'm going to say that this nurse here is probably at the med cart, which may be over here. Med cart. And this young lady with something in her hand is probably the recorder, which is really one of the most important positions in a trauma, is the person documenting everything. The thing I want you to know is just look at there's so much going on, and yet I'm pretty sure that everybody knows what's going on. So I just happen to like this picture. Remember, guys, trauma is based on 3 principles: critical thinking, evidence-based practice, and prioritization. If you remember these things, everything we do is going to be based on these concepts. Few key things to remember. The initial trauma survey is based on A to I, and that provides our systemic flow. Primary survey is airway, breathing, circulation, disability, exposure. Secondary is our full set of vitals, our adjuncts, our head-to-toe assessment, and inspecting the posterior. I want you to remember that teamwork is really the key in any trauma activation. A good trauma team works seamlessly, guys. Each member knows what their job is and knows the job of the guy next to them. When you see a great trauma team at work, it's really like watching a ballet. Finally, like we just said, don't get tunnel vision. It's very common for nurses to focus on one thing. Like if a guy comes in stuck with a knife in his chest, everyone focuses on the knife. Don't forget to see if he's actually breathing and has an airway. Make sure that you always take in the full patient, not just the individual injuries, right? So, thanks for joining me in our intro to trauma, guys. There is a lot more to come here on NRSNG, so I hope you'll all tune in again. And as always, happy nursing!